It's, as Georgina said, it is really energizing seeing the breadth of professions here. There's nurses, there's GPs, midwives, project managers, commissioners, and yeah, I can feel the energy. So thank you so much for giving up your time for being here. And I'm delighted to say Dr. Paula Cowan is also on the call, and she will introduce herself after me, if that's okay, Paula. So
Yep,
I'll
no
carry
problem.
on. I'm conscious of time. Thank you. So why this programme? We are looking to test scalable models for women's health support outside the acute setting to improve patient confidence, understanding and adherence to self-care of women, or signpost to an appropriate service. We want to enhance women's health capability, impacting the national gynae waiting list. And you may or may not know that it's just not acceptable, the length of the waiting list. And as of December 2025, data, our NHS England data shows us that the national gynae waiting list is over 570,000 patients waiting to be seen. And of those, only 57% of women are seen within the 18-week standard, which is below the average for other elective specialties. And nearly 30,000 people have been waiting over a year. And many of you will know this, often with symptoms like chronic pain, heavy bleeding, or incontinence. And as Paula Cowan, who will be speaking shortly, educated me, 80% of women are discharged after their first outpatient appointment. So that's obviously huge. We want to develop 7 regional centres of excellence and expertise in group-based approaches to delivering women's health services, and to create learning to inform the development of neighbourhood approaches to the women's health service delivery. And we know that women often describe fragmented pathways, repeating their story multiple times, many delays seeking help due to normalisation of symptoms such as stigma or caring responsibilities. And we know that trust is built through continuity, familiar faces and non-clinical spaces. And women want services that recognise the intersection of health, social and economic factors. Next slide, please, Georgina. Thank you. So neighbourhood health and group clinics. We've listed some characteristics of neighbourhood group clinic, and I'll summarise at the end. So it's to proactively support people with complex care needs. And I'm aware, just to say, we're pitching this, people have got different levels of knowledge and confidence around this, so I don't want to patronise anyone. So I'm hoping I'm pitching this at the right level. So with complex care needs and family carers who are requiring support from an MDT as equal partners in their care, and that's key. And it can take place either face-to-face or online in community settings. We can talk about that a bit later on. Georgina will talk us through group clinics. They deliver proactive, preventative, personalised care that will build knowledge, skills and confidence to self-manage and maintain independence. They're scheduled frequently with people and carers attending weekly, monthly or even daily as and when it is required. And often there is a drop-in option that's offered for those that are becoming unwell, supporting care coordination delivered by the MDT, many of which of you are here, and involving voluntary community, faith and social enterprise partners. So essentially a neighbourhood group clinic model delivers planned care to groups of patients with similar needs rather than one-to-one appointments within a defined local neighbourhood, and care is provided by an MDT neighbourhood team, combining clinical review, education, peer support in longer group sessions. So the model involves access and self-management while helping neighbourhood teams to use clinical time more effectively and deliver their care closer to home. Next slide, please. Thank you. So expected outcomes of this piece of work is to improve patient activation levels and patient reported outcome measures. It's to improve workforce development, job satisfaction and retention, which I'm passionate about all of it. But as a nurse and an ANP, I've worked in secondary care actually my whole working life, but that's just so important to me. Job satisfaction, value, retention, utilising our skills. And Dr. Paula Cowan is very supportive of that because we do talk about doctors a lot, and we need doctors, of course we do. I don't feel still that we're utilising our wider workforce, providing case studies and economic evaluation to inform future commissioning. And I think this is where I introduce Paula for the next slide. It is.
Hi, thanks Tara
Thanks,
for
Paula.
that, and thank you all. I hope you can hear me. Really sorry for being a little bit late joining. This is the peril of Teams meetings, isn't it? That we now work back to back, don't we? And where's the thinking time? And I hope that you find that through this next 45 minutes that you have some thinking time to think about group consultations and how that will work within your regions and then systems and places. I'm Paula Cowan. I'm Regional Medical Director for Primary Care in the Northwest. I'm the national specialty, one of the national specialty advisors for gynecology, working with Sue Mann, National Clinical Director, and the wonderful team that we have around, and work very closely with Tara and Michaela and all the others, and now Georgina through this group consultation work. And there's a lot that we can do in terms of group consultations, and I'll walk you through some of the pathways here. We will share some of the recording and the content of the slide, so I'm not going to read it out for you all. You're all very well able to read, but a couple of things based on what Tara has just said, and I think it's really important that we recognise that so many patients who are referred to gynecology clinics can actually be managed closer to home, can be managed in settings that don't necessarily necessitate a consultant in secondary care, and that figure of 80% is very real and very live at the moment. And so what can we do in general practice and primary care to support our patients? And I'm a GP. I've been a GP for 23 years as a partner in a practice in the Northwest, and I'm lead for gynae and sexual health within my practice. So I see a lot of women with all of these conditions, and we have, and I do have experience of group consultations because we have started that journey within my own practice. And the other thing that I really want to stress here is that when we talk about clinical input and clinicians, I'm not just talking about GPs. You know, we have to absolutely recognise the role that all clinicians across community, general practice, wider primary care, secondary care play. And that multidisciplinary team approach is so hugely important. So, you know, doctors and nurses and advanced practitioners, social prescribers, lifestyle coaches, all working together to deliver what's best for our populations. And today we're talking about women's health, but actually there are group consultations around, you know, other long-term conditions where the input of, you know, non-clinical multidisciplinary team support is so hugely important. So when we talk about some of the priority group pathways for women's health, looking at heavy menstrual bleeding, and I think it's really important that, you know, we look at that in a group consultation for any of these pathways. My experience is that patients feel actually that peer support, sitting being either in a virtual group or in a real live person-to-person group, that peer support and actually, you know, talking about menstruation and normalizing how we talk about menstruation, but not normalizing some of the symptoms that women have and that patients with heavy menstrual bleeding have. So being able to talk about the fact that it's not normal to stand up from a seat and look back at the seat to make sure you haven't bled through your clothing. It's not normal to have to wonder, what will I wear because I don't want to soil my clothing? And it's not normal to have to take so much time out of work and school and the impact that that can have psychologically, socially, physically, mentally. So the group approach helps to decide and discuss what investigations are required, and then looking at the management options in terms of heavy menstrual bleeding. So I'll often talk to patients, and when we've done the group consultations, talk about non-hormonal manipulation or management, hormonal, and then looking at intrauterine systems, etc. And then talking about identifying causes and facilitating appropriate referral. And I talk about appropriate referral. There's lots that we can do in general practice and wider primary care to address some of the issues around heavy menstrual bleeding, but actually then knowing when to refer on. And some of the conditions that we see in heavy menstrual bleeding include endometriosis, fibroids, polycystic ovaries, etc. And early recognition, early consideration and referral on is really important if required. Next slide, please. other areas for consideration and for discussion, and some of these areas we are discussing with our national colleagues through the NHS Online, is urogynecology. And again, that peer support for patients, for women in particular, that we're talking about here in terms of prolapse and urinary incontinence, and actually taking away the stigma and taking away the shame that some women feel when they have urogynecological conditions and where they are having incontinence, and the embarrassment and the fear of not being able to go out, to wear certain things, to be frightened of coughing or sneezing in case they leak. And actually that conversation around conservative management, pelvic floor therapy and pelvic floor exercises. And this is where actually bringing in clinicians who are experts in pelvic floor physio into your group consultation process can be really, really beneficial. And then the discussion around surgical referral and when that is needed, and talking about improving quality of life also. So next slide, we talk about our next condition that we would consider for group consultations. And the next one is obviously looking at if we go back a slide, contraception. So contraception leads itself really extremely well open for discussion through a group consultation. So many of our younger women are getting their information around contraception from TikTok, which is somewhat worrying in terms of the advice that they're getting and stopping their contraception because the perception that it increases weight and it has an impact on so many other aspects of life. And actually then we see unplanned pregnancies. So it's giving that peer support, talking about all aspects of contraception, from combined oral contraceptive pill, progesterone-only pill, and then the other progesterone long-acting reversible contraception, so depot, implant, coils, etc. And I think what we haven't put on the slide here, but it's the myth busting, particularly around some of the contraception devices like implants and coils, be that a hormone coil or a copper coil, and actually addressing some of those concerns that we do see in social media posts, and addressing the concerns around the fitting of implants and intrauterine devices. So I think it's really important to encourage and support those peer discussions. And also the benefits then obviously in terms of supporting reproductive choice, but also addressing the issue around unplanned pregnancies. And then the next slide is talking about menopause, and certainly some of the group consultations that I've done in my own surgery are around menopause. And this is hugely important because I often say, and Tara is tired of hearing me say this, that we prepare younger than teenagers, year 5 and year 6, for what's going to happen at puberty. So body changes, periods will start, guys will, grow hair, the muscles, their voices will change. We prepare them from year 5 and 6 onwards, and then into year 7. We talk about what will happen. Up until recently, we haven't been as good at talking about what happens at the end of reproductive life. I'm not talking about the end of life, I'm talking the end of reproductive life, and that perimenopause and menopause. And actually, I think group consultations lend themselves so well for this. And my experience is that the patients who attended the group consultations around menopause and perimenopause have been really buoyed up and excited by the fact that they've been able to hear other people's symptoms and hear other people's issues as well. And that's peer support is really important, because perimenopause and menopause happens at a time in a person's life when there's so many other changes as well. You might have children leaving the nest and going to apprenticeships or to college or to university, or leaving to go and work in other places. And also then you become the carer in some regards for aging parents. And so there's so many different things ongoing at that time that group support, looking at perimenopause and menopause, and for those experiencing menopause, and then talking about premature ovarian failure, so the early menopause in patients who've had cancer, and what they can and cannot use for managing their menopausal symptoms. And then, of course, obviously the other impact on bone health and cardiovascular disease, and actually having that discussion. And I'm not going to say normalizing it, but making it okay to be able to talk about it. and again, dispelling some myths that we sometimes hear through social media. Social media is excellent for sharing and for highlighting issues, but sometimes there's a lot of emphasis put on it that I would worry in terms of some of the clinical aspects of care. And I think that brings me to the end of our pathways, Georgina. So I'm going to hand back over to yourself. I hope that that's been useful. But please do put any questions or comments that you have in the chat, and hopefully we'll have some Q&A at the end. Thanks.
Yeah. Thank you, Paula. And I think the point that we want you to, this is to get you kind of thinking about areas that we've identified nationally as being, you know, real priority areas. It doesn't mean to say if you've got a local pathway that is, you know, where you can really see the potential of the group model, that wouldn't necessarily be something that you could do. Of course you could, but these are sort of some of the ones where we need some best practice generated. We need some, you know, insights, some case studies to help us to sort of really scale up the group approach. So these would definitely be areas that we'd be hoping that our vanguards would be focused on. The other point that I just wanted to make is that there's obviously some overlap between some of these pathways. So for instance, menopause and urogynecology, there's going to be some overlaps there. So exactly as Tara talked about, you know, you could see how that neighbourhood group clinic model where you've got an MDT supporting a group of women would be something to think about as well, you know. And Jessica's just mentioned in the chat about chronic pain, especially around pelvic, and you know, Jessica, as I've just mentioned, it's not a question of you know, it not being important. You know, it's definitely an area where we would want you to think about bringing those ideas to the table, particularly if you have very long waits around those things. So what support will vanguards get? Let's just give you an idea. So the timeline, first of all, is really important. We've tried to make it nice, and so we don't want to just sort of like pounce on you. We want to give you time to engage and engage your team. So we will be looking to receive applications from you by the end of April. So hopefully that gives you a good bit of time to think this through. We will select the vanguards latest by the end of May, but those successful vanguards will be also onboarded by the end of May. The reason that we've given a month for this process to happen is that we want to make sure that you have a sponsor within the ICB who is going to support you in this work as well. Not necessarily financially, but, you know, in terms of giving you that kind of advocacy that you need to make sure that you get to do this work well. So we will be working with the 7 vanguards that we select to make sure that their kind of local kind of governance and support arrangements are nice and robust, and that's why we've given a bit longer to actually go through that process. As soon as you're onboarded, you'll be able to start your training, which a lot of it is self-study, but there will also be a face-to-face mobilisation day. That may require you to do a little bit of travel to reach that mobilisation day, because we've got 7 vanguards across the whole country, and ideally we want you to all be in the same place. So that's something to think about, but it will be a day that you will have to invest to do that. Your co-design sessions will generally be virtual online, so that's not going to be, and they will be organised to fit with your availability. But the mobilisation days, we will probably have those kind of a little bit set in stone, and we'll give you the details of those very soon after you are you know, you come on board. So you'll have several months to prepare for those well in advance, to sort of put people in people's diaries. At the mobilisation days, you'll also do a dry run and get to see how that works. And then you'll go away, you'll do your own dry runs a week before you go live, and then you'll go live with your first group clinic models in September and October. So by the time we meet with you, we want you to have those first group clinics booked in. basically. And then we will work with you over the ensuing months to create some case studies, capture that best practice. There will also be the need to for you to feed some data into a little evaluation hub after each group clinic, and to participate in an independent evaluation. So the vanguards that we appoint will commit to supporting an integrated model of women's health and neighbourhood working, to embed evidence-based practice, to use the group clinic programme to build their workforce capability and encourage their system and their place to adopt group clinics as part of sort of routine clinical practice, to prioritise and sustain the group approach, so this change, and also to participate in our quality assurance and evaluation processes within the programme. And also to commit to being mentors. We often talk at ELC about expert mentors. We know that you as vanguards will be key to the adoption of this model across your region, and we want to make sure that you're open to that. Now, we've got I don't know if Rupa's on the call today. Rupa, if you are, can you unmute? But Rupa is a GP who's done a lot of work around group clinics. I don't think she's on the call. I don't know if Dipti, if Rupa's not here, if Dipti's on the call today from Croydon, but the reason I was wanting you to unmute if you are is because both of them, in effect, have been acting as peer mentors around group clinics for about the last 5 or 6 years. They were early adopters of the model in primary care. And from time to time, they'll get emails from me. They get lots of emails from other people saying, oh, I hear that you're a bit of an expert on group clinics. Can you tell me a bit about it? And that is what we mean by peer mentorship. We're not talking about you having to give up huge swathes of time, but you're going to be like an asset, a resource within your region, a place where people might come and, you know, see what you do and how you do it, you know, that kind of thing. But it's not going to be a really onerous role on you. Okay. Oh, lovely, Anna. Thank you. I don't know. You've been involved in brilliant, fantastic. So I'm sure that you can pop into the chat, Anna, how, you know, what you've observed around Dipti's involvement in kind of being a bit of a local mentor around this. So the expression of interest process, we're aiming to keep it fairly light for you. So we're going to send everybody who's registered for this webinar, and there's 300 people who've registered, an application pack by Monday of next week. We will, if you haven't received it by close of play on Monday, if you wouldn't mind letting us know, so that we at info@elcworks.co.uk, we will send a little email out to everybody who's after this with the recording and also these details of the EOI process. That would be really helpful because we can make sure that we do send it to you. There will be a guidance document that runs through some of what we've covered today, and also an an expression of interest registration form, and an MOU, memorandum of understanding. You need to complete the registration form, sign the MOU, and return both to this address. And then we're giving you more time, so that's got to happen by the end of April, and then you'll have time to go away and talk to your ICB and find that sort of SRO senior person who is going to sponsor you should you be selected. So we're not going to put you under the pressure of finding that person before you actually complete, well, when you complete the EOI. SOR, can you remind me, Tara, what SRO stands for?
It's Senior Responsible Officer.
Senior Responsible Officer. Yeah, thank you. That just slipped my mind there. So there we go. So that's hopefully that feels like it's fairly light touch and not too onerous a process for you. So
Okay, so we're going to move on now to read a bit about what Dawn Langdon and her team have done at Thanet Health Kick. Unfortunately, the recording has failed at this point in our webinar, so I give my sincere apologies for this. So I'm just inserting this video now into the recording so you can read up on Dawn's slides. So please do press pause to read each slide in turn. Okay, I'll unpause this now and you can listen to the tail end of Dawn's presentation and the Q&A. Thank you.
Away the need for your one-to-one appointments. If you're doing new work, if it's a new service like this one, clearly it does need to be funded. You know, there's because you're sitting outside of general practice and taking work off general practice, aren't you? So that's a sort of the women's health hub model. But if in general practice, you know, women would have to be seen anyway, that's a slightly different situation. Rebecca, you've written a really long email about this. What did you want to add to that?
Yeah, sorry, can you hear me okay?
Yeah, we can.
Yeah, so it's just easier just to actually speak rather than just to keep writing in the chat. I'm really excited about group consultations. We're doing a pilot at the moment, which is fully funded for weight management, and other places are doing women's health ones. My issue is that there's very little data around. You're saying it will reduce one-to-one consultations. That's an assumption unless you have the data to back that up, that these patients then don't go on. Great, that's really good to hear. That was my first question. And you know, I do dispute the notion that it's saving you appointments, therefore you can just free up, but actually it is releasing people to be trained to work in a completely different way that they're not used to. They do need support for that. They do need time taken out of clinics to do that as well, to have the additional support. So it's not like for like or even cost saving for general practice at the moment with the current models. So I don't think we can kind of look at it like that. I do think funding is still an issue.
Yeah, I mean, there's no doubt that funding is an issue. We you know, we have to. The only thing, you know, there is within the program that we shared with you, the Centres of Excellence program. I think, if I'm honest, I think the way that has you to take that forward is to work in partnership with your specialist gynecology services locally who've got this pressure to reduce their waiting lists, and look at how you can make a business case for taking away the pressure off the waiting list, that, you know, and they will have funding to support that. And that's the way it has to go. And it's a recognised issue across the whole system. You know, we've got too much funding in hospitals, not enough funding in primary and community care, but we need to show that we can solve that problem, and then the funding will hopefully follow. You know, I know from conversations that I've been involved in that, you know, this next financial year there may be more sort of pressure on acute providers and money released into primary and community care. So we need to skill ourselves up so that we're ready to take on that work. Rebecca, if you've already done weight management, it should be quite a small leap for you to do, you know, your second pathway if you do go moving on to women's health, because you've already got some capacity and capability within your system. Hopefully you've set up all of your admin processes already for weight management group clinics. So we often find when we work with people that the leap to the second pathway is a lot less painful and takes a lot less time than doing the first pathway.
Yeah,
so
I do appreciate what you're saying, but that's at practice level. It's not at PCN level, and it's not a neighbourhood level. So when you're saying it needs to be upscaled to you know, PCN neighbourhood trust level, then that's a lot of work behind the scenes that is not being
It
recognise.
doesn't necessarily be you. You guys could be part of it, but you might not lead. You know, you might not be the lead applicant organisation. I think that's the thing. Who stands to gain from this new approach? That's how we'll work as neighbourhoods, isn't it? By working collaboratively. But I do hear your concerns, and I recognise them, but.
Well, I had some reservations about the trust kind of, dictating to us as to how group consultations need to run, and yet we're meant to kind of be doing the group consultations on behalf of the trust. That doesn't work as a model for me as a GP. So yeah, there's just a lot of kind of questions really that make us a bit reticent. And I think an acknowledgement that we have a new contract coming out in the beginning of April, which we're not happy with. We're likely to be taking collective action on that. And there's a lot of funding issues in general practice. In general, most of my practices locally have lost money this year and lost income. So these are what you're facing. We're very keen to get involved in projects, please don't get me wrong, but there has to be some funding attached to it.
Yeah, absolutely. I feel it. I feel you. Okay, so I've got a couple of other questions in the chat here. So Dawn, where do you hold the group clinics? Is it in a GP building? I'm struggling to work out where I put a group of patients. Yeah,
it's in a GP building that I do it.
Yeah, and the other thing you can think about is community buildings as well. So that's another way that you can involve the voluntary sector as well, isn't it? You know, if there's a community centre or that kind of thing, that's worth exploring.
We've also used because I'm actually subcontracted. I work for a community interest corporation, non-for-profit, and we work for all the GPs in Thanet, and we've done them here as well. So outside of that GP practice.
Yeah,
so and then, a bit of both.
Brilliant. And then we've got a couple of questions from Dawn Davies. So she was asking what's your population?
153,000 Thanet patients.
Brilliant. And then also, what was the other question that she asked as well? Do you do video group clinics as well, or are you thinking about doing them?
Funny you should say that. I've done them all face to face, but as I say, I'm doing my diploma, my MCPD at the moment, and my trainer runs virtual groups, and I've been invited as part of the diploma to sit on there. So I've sat on ones with Sue Mann a few years ago, but I wanted to sit on hers, and that's an option for the future. So maybe in the future. I don't know. It depends on funding. My colleague said
you're kind of open to it, but not done it yet.
Yeah, open to it, but I've not done it yet.
Yeah. Okay, brilliant. And then Jan says, I'm a lead practice nurse and I lead on chronic disease for diabetes, COPD, asthma. My concern now is having to be an expert in HRT to be able to run a group clinic. So I guess, the opportunity is to skill yourself up, Jan, isn't it? We've got another practice in Kent and Medway. The GP started off as being the prescriber of the HRT in the group clinic, and then the nurses undertook some CPD, and then they have taken over the group clinics from the GP now. So that's enabled the GP to walk away a little bit from HRT prescribing and upskilled the nurses. And you've upskilled yourself, Dawn, as well, haven't you? So you can do that.
I think you do. I mean, they did. They had their sort of they did a lifestyle with social prescribers in Medway, as far as I was aware, and then they get a second appointment or a second group, don't they, where they look at the HRT prescribing. But I've upskilled myself. But
Yeah, you have to. I mean, if you're not, you have to work within your competence, obviously, at all times. So if you're not able to prescribe, you could, you can look at a sort of iteration of the model where you bring in a prescriber, or quite a lot of people do a group clinic, which is kind of like, preparing people to take the decision, and then they do florries for the actual prescribing and various things. So there's a number of different ways you can do it, but you shouldn't be obviously feeling uncomfortable about prescribing HRT if it's not within your competence. Then definitely need to be skilling up or working with a prescriber who is ready to do that. And then I'm going to take this final question and then move over to Alicia to finish off. So Vicky said, presumably, if you were a smaller practice, you might invite less patients in at a time. Vicky, I would say that what we know from the best practice is that a group clinic works best with about 8 to 10 patients. So even if you're a small practice, you should still probably be aiming for that kind of number, but you might need to do them less frequently. So you might only do, say, one a month if you only have a small list. So I don't know, Dawn, if you would agree with that. I'm sure you see that kind of 8 to 10 as that magic number, really, when it comes to engagement.
Yeah,
Definitely.
yeah, definitely.
Brilliant. Okay, so let me hand back to Alicia to close the session. Thank you so much. Your insights are really powerful, and I think you've really made it real for everybody. So thank you so much.